Hello, everyone. It's really wonderful to be meeting you all in through Phoenix 2021, the state conference of the Indian Association of Public Health Dentistry Kerala chapter. It is indeed really wonderful that virtual meetings such as this can help us come close together. I am Dr. Vivek Narayan, Assistant Professor in the Department of Public Health Dentistry, Government Dental College, Kottayam. I will be talking on home-based oral palliative care avenues for dental public health. So without much time, let's go into the topic. I'm sure most of you here would have heard of palliative care, but then let's see what I have in this presentation. I will be just dealing with a background, a small introduction into what palliative care is, what it is all about. And then I would touch upon the highlights of the palliative care model in Kerala, which is talked about in the country, which was it's a pioneer venture in the country. And then whether at all there is a need for palliative oral care. Then I will be moving on to a small experience of having done oral care in a palliative setting at Kottayam. And then finally, I'll be discussing how palliative oral care can be incorporated into dental public health. What is the way forward? So as I said, what is palliative care? We all would have heard this, probably. I heard this 20, 25 years back. And then I thought it was something to do with the end stage care of serious diseases like cancer. But rather, palliative care, according to the World Health Organization, it is a whole new approach of improving quality of life of not only patients, but also their families. Whenever any life-threatening illness, it could be cancer, it could be stroke, it could be a fall which causes a serious spinal injury. Even non-communicable diseases like diabetes, when it becomes uncontrolled, all these require a palliative care approach. It's basically targeted at preventing relief of suffering, prevention and relief from suffering. It involves identification, assessment, treatment of pain and other symptoms that may occur during the course of the disease. Importantly, it not only addresses the physical problem, it also addresses other dimensions. Like whenever we have, suppose like we can talk of COVID-19 now, even though we may not be affected, we know there is a serious psychosocial element to it. Any disease can have this problem. It can work on the mind. So a palliative care approach involves creating positive feelings in the mind. And as I have already mentioned, care is not only a problem for the patient, it is also so much for the caregiver. And it is the relationship that is important. Therefore, palliative care is oriented towards both the patient and the immediate family with physical, psychosocial, and spiritual elements incorporated into the approach. Okay? We will learn more about this. Now, to understand what I'm talking, it is better to differentiate three terms. As shown in the figure, there are three terminologies. One is palliative care, the other is end-of-life care, and finally, we have what is called as terminal care. Understand that palliative care is the broadest of all this. It starts right at the point of diagnosis. It involves symptom management. The chief focus is to improve the quality of life. Like, what do you mean by that? It just means that the whole approach is targeted at making the patient feel relaxed. See, even doing our household chores, waking up in the morning, brushing our teeth by ourselves, taking a bath, all this will add to what is called as quality of life. In a patient who is bedridden, who has serious problems, the confidence that he can take care of himself or herself, he or she can take care of himself or herself itself is a big thing. And these are small examples of how we can improve quality of life for such patients. There is some surgical treatment modalities also. The most important being psychosocial support. That is what you must remember from palliative care. Remember, we should be able to be communicating with the patient. We should be able to speak to them, respect them as an individual. When we start doing that, they will feel confident about their own life. They will start feeling that their life is almost normal and we are there to help them. So this is all about palliative care. So just think about a bedridden patient who needs a help, a medical help. He or she can't go to the hospital on their own. So palliative care today is totally focused on home-based care. Rather than putting them into an isolation ward with no one to look after them, it was realized that the more care you can give in their own natural setting, the setting of their house, it would be more wholesome. So palliative care today is more about home-based care rather than a hospice-based care. But as we know, major diseases like cancer, probably the examples that I took earlier, will probably can't go to a stage where it can't be cured. And then we will need to think about end of life. Think about a renal patient who has to get a dialysis every other day. And still, there is a human element in them in trying to make their life normal. So, still, there is scope for symptom management and psychosocial support. Now, coming to terminal care, what is terminal care? Now we are talking about the last few days or hours of life. Now, just imagine, just ponder over this question. How would you like to spend the last few hours of our life? I know it's a difficult question, but still, it's worth pondering. Do we want to spend our end in a hospital bed with no one to take care of, or would we like to do it in a more or less friendly setting with our relatives nearby, with our near and dear ones nearby to hold our hands? I definitely feel most of us would prefer the latter one. So that's about palliative care in the terminal days. It is about making the end as peaceful as it can be, providing support to the family as well as the patient during this critical hours. So I feel I have explained the difference between palliative care, end of life, and terminal care. What we are going to discuss in the rest of the presentation is only about palliative care. With respect to oral care, we know that we are not involved in the end of life or the terminal stage care. Mostly what we will be dealing with is palliative oral care. So remember, it is not only about cancer patients. Though palliative care became very popular with treating cancer patients or which involved cancer, slowly it began to expand into other areas also. Today, we have patients with all sorts of debilitating diseases like stroke, non-communicable diseases like diabetes, and also trauma patients, and also the intellectually disabled children would come under the ambit of palliative care. So that is an introduction to palliative care. Now, coming to what has been done on this aspect, well, the pioneers of in starting palliative care in India is our Padma awardee, Sri Dr. Emma Rajagopal and Dr. Suresh Kumar in Kozhikode. Their beginnings were very humble when they formed a pain and palliative care society in Kozhikode Medical College in 1993. Dr. Suresh Kumar was an anesthetist who thought something really should be done for pain relief. And later on, there was a major policy shift. In the early 2000s, they realized that they can take this forward only if they involve social networks. The immediate people in the community had to be involved to take palliative care forward, and thereby resulted in the formation of what is today called as neighborhood networks in palliative care. This was pioneered in Malappuram district of Kerala, which became very popular and is still today regarded as where palliative care has reached heights unknown to other areas. The crowning achievement happened in 2008 when the government of Kerala actually took this up as a policy. Till then, patients in the debilitating disease category, especially from the impoverished sections, people who did not have money, people who did not even have money for 3 square meals a day, they were being pushed into isolation wards in government hospitals, which were already in a pathetic condition. So the government came forward and introduced what is called as a palliative care policy with a thrust on home-based care. Now, this was a big step which actually directly uh, sent a message to the community that palliative care is very important. One more thing which they did very craftily was that they made palliative care under local self-government, simply to say panchayats. So if panchayats, we know that each primary health center in Kerala is run by the panchayat in which the PHC is located. And the total cost of palliative care has to be borne from the funds of the panchayat. Now, they also made a rule that if the panchayat fund or the budget proposal of the panchayat had to be sanctioned, there had to be definite allocation for palliative care. This really changed the scene, and we saw in the coming years that palliative care was welcomed by the people of Kerala. Subsequently, in 2010 and 2012, we had 2 institutes in Kerala recognized by the World Health Organization for training in palliative care. The Pain and Palliative Care Society got transformed into the Institute of Palliative Medicine. And under Sri M.R. Rajagopal sir's guidance, Trivandrum Institute of Palliative Sciences, an NGO, was formed, which mainly focused on guiding on morphine use. Now, why are we talking about this? It was because in 2016, the Kerala University of Health Sciences brought palliative care under the undergraduate curriculum of the PDS course. And it was decided that it would be dealt by the public health dentistry faculty. Now, remember, this was at a time when even the MBBS curriculum did not have palliative care. So that was a big shift that shift in policy that happened from the KUHS, which actually recognized that dental students also need to be trained in palliative care because there was a need for human resource in this field, and dentists could do a big role. So we are talking so much about Kerala because remember that when not even say 3% of India's population today have access to palliative care. These are not my words. These are words in a published research. And imagine 2/3 of the care available comes from Kerala. Both public as well as private sector is actively involved in palliative care in Kerala. So Kerala is a scene where palliative care is already working, and the time is apt for extending oral care into the palliative arena. So why is the Kerala model so talked about? Mainly because community mobilization. Today, palliative care is taken up by local people, both wholeheartedly by the local community, and that is the reason why it became so successful. Palliative care was incorporated into the 3-tier healthcare system of Kerala. Like in the healthcare, we have the primary, secondary, and tertiary level. In palliative also, we have primary, secondary, and tertiary level care, which we will be looking in just a few minutes. The thrust of the policy was home-based care, and a group of healthcare workers called the palliative care nurse were developed. They are the leading caregivers in palliative care policy of Kerala. They were trained specifically to deliver palliative care to the needy persons. And as I've already explained, the involvement of the local self-government, the funding of the primary and secondary palliative care comes from the funds of the panchayat. This was one practical step which ensured that palliative care happens correctly and outcomes were properly ensured. So today we have more than 900 palliative care nurses who walk into the homes of registered patients and take care of them. Similarly, the funding as to what all should be bought, how it should be procured, all these decisions are taken not at the central level, but at a decentralized level, at the level of the local panchayat. According to the need of that particular setting, palliative care is addressed. So it's a very good example of community mobilization, a great example for us dentists to learn on how we can lobby the government to ensure policy happens. And when that policy happens, it ensures that this approach is taken into the common person's mind. So there is palliative care is a fine example of how healthcare can influence policy. So just let me give a brief outline of what is happening in palliative care today. As I told you, it is organized into primary, secondary, and tertiary levels. In the primary level, we have home-based care, which is chiefly being performed by a palliative care nurse. We have the junior public health nurses, or anybody with even a diploma in nursing can undergo a training to become palliative care nurse. They are assisted by our ASHA worker and a driver who is specifically recruited for this purpose. The vehicles are mostly taken on rent on a 1-year basis, and so that maintenance is ensured. There is a small vehicle which allows these people to go to the homes. The finance, as I have explained, totally comes from local self-government, and the supervision of care is done by the medical officer at the primary health center. At the secondary level, again, home-based care is a thrust. We have a better trained nurse who can do less invasive procedures, better knowledge on catheterization, better knowledge on wound management. All that is very important in palliative care. So generally, the secondary palliative care nurses are better trained, and they cater to 4 to 6 primary care units, which come under them, more or like how our secondary healthcare system is organized. Again, here the medical officer also goes on home visits. Also, we have physiotherapists. For example, as I told you, most of these patients become very less active physically, or they have serious psychomotor disabilities. And therefore, physiotherapy and counselors form a big role in the secondary palliative care system. And this is where I believe oral health also can be incorporated. Rather than in the primary, it would be more feasible to incorporate oral care into the secondary palliative care system. This also is financed by the local self-government bodies. And finally, we have the tertiary care centers at the district level, where there is facility for inpatients, although they are not as developed in the government sector, but the private sector has a lot of good end-of-life care institutes in Kerala who cater to the end-of-life and terminal care. All the training for all categories, for the doctors, for the palliative care nurses, the physiotherapists, all are handled by the tertiary level hospitals. Most of the district hospitals have training centers incorporated into them. And at this level, the financing is directly by the state government. So this is a brief picture of what is happening in the palliative care scene in Kerala. Now, let us think whether oral care is a requirement. We all know that oral health is inseparable from overall health. It affects happiness and general well-being. If a person can smile, I'm sure their ability to form social relations is going to be much better. And if they have a clean mouth, their oral hygiene is good, they won't have bad breath. And this again ensures that they're going to be feeling comfortable and positive about it. So this itself is an important example of why oral health is important. We know from the global burden of disease study conducted by the World Health Organization that oral diseases can be called as the most common non-communicable disease that is affecting humans today. Take any population of the world, we will see that dental caries and periodontal disease are so common and they are ignored often. And they form the huge burden of non-communicable disease. And the fact that poor oral health can lead to poor systemic health also needs to be kept in mind. Now, there is it's very difficult to manage oral hygiene and oral care for the institutionalized elderly. The elderly population is increasing day by day, and Kerala today has 12% of its population at over 65 years. And therefore, the need for domiciliary or home-based oral care is increasing day by day. When you come to the broad section of the society, the impoverished section, probably they don't ascribe as importance to oral care as we would like to, because they are facing a huge burden of problems that they don't worry about oral care. But the fact is, people are suffering from toothache, from sharp teeth, from poor oral hygiene, etc., etc. Therefore, there is a huge unmet need of oral care among the institutionalized elderly or among the palliative care patients. And there is a huge amount of work to be done. There are a few studies also which have been conducted in this regard. The common oral health problems that we see in palliative care patients are, of course, toothache and traumatic ulcers due to sharp, ragged edges of the teeth. There are going to be ulcers on the sides of the tongue, on the buccal mucosa, etc. Poor oral hygiene because they're not able to, they don't have the manual dexterity to take care of their teeth well. That is a serious problem. Most of the time, periodontal disease progresses and leads to mobile teeth, which may cause discomfort to the patients. Most of these, especially cancer, most of these patients, especially patients who have undergone radiotherapy, are likely to have xerostomia or feeling of dryness and causing widespread mucositis and oral ulcerations and pain. Candidiasis is a serious problem in uncontrolled diabetes, and again, it's going to worsen the oral health. In the few patients that have dentures, they are going to have problems with loose dentures, sharp edges, etc., which need adjustment. And denture care, of course, is going to be a big concern. So these are the common oral health problems that we see in palliative care patients. So now let me talk about what we have done or tried to do at Kottayam. Ever since KUHS brought out this policy of incorporating palliative care, we were wondering on how to train the undergraduate students and what can be done in this arena. The first thing that we did was the entire department, all the faculty members, the junior residents or the postgraduates got trained in palliative care. There was a 10-day foundation course, which is still happening in all the general hospitals, which is open for doctors in the government service. There are other avenues for training also, which I'll be dealing at the end of the session. So this 10-day palliative course was an eye-opener for all of us. It was a well-planned course where theory sessions as well as home visits were incorporated. The training happened at General Hospital Kottayam under the able guidance of Dr. Sarama, who was a retired plastic surgeon who has now devoted her time for palliative care, and Rija Madam, who was a physiotherapist there. Under their guidance, we got a beautiful course including home visits, which actually increased our information on how palliative care works and what can be done for the oral problems. So getting trained is a very important first step. The home visits was what changed everything. They were such a great learning experience. Each person, each palliative care patient had their own story to tell. And I'm sure if you talk to different persons who have got this training, all of them would agree that home visits is what transforms us and develops our interest in palliative. You can see this old lady who was treated for oral cancer, and finally now she was in palliative care. You can see the palliative care nurse and the ASHA worker who takes care of them. And the house that you see in the background was built for them by the panchayat. So this is a clear example of rehabilitation, social rehabilitation, economic rehabilitation, where the life of the, remember, there were no children, only her and her husband were living in that house. So they, because of the huge burden of cost that the cancer has caused, but still they are today able to live a decent life because of the palliative care team. And why I put these two pictures is, while we have visited most of the houses that we see in government palliative care come from these really poor or backward sections of the society, we have patients from these kind of houses also, the relatively well off, who are bedridden, who lack proper communication. There's no one to hold their hand and talk to them about what their little needs are. We have visited such houses also. And then we learned that life is a great equalizer. When disease affects both all sectors of the economy. And these nurses really must be commended for the work they do. As you can see, they have to cross all kinds of terrains. Carrying the kit, they have to walk through long distance through fields, through difficult terrain to reach these palliative care homes, the homes that are really there at the most basic environment or the economically deprived sections of care. This was a real eye-opener, at the same time, a great learning experience as to the different aspects of life. So after this, after we received training on palliative care, it was our turn now to train the palliative nurses on oral health. Obviously, they were already trained. There was a WHO manual which also talked about oral care for palliative patients, but still it needed reinforcement. And our department has been called in several times to continue this training for the palliative nurses on oral health. This happened at the NHM hall in Kottayam at regular intervals. Following this, we actually developed a screening form in the local language for oral health problems in palliative care patients. Now, that's how we start the work. The first point of contact is the palliative care nurse. Whenever the palliative care nurse who goes on regular home visits identifies patients with toothache or dental problems, they are required to fill up this form and then send it to us through email or WhatsApp. And then this forms the basic oral screening of that patient. The palliative care nurse also trains the patient as well as the immediate caregivers on basic oral care instructions. This form is then scrutinized at the public health dentistry department and a decision is taken whether to plan a home visit. If so, what is the likely treatment that is to be anticipated? Whether an extraction can be performed, whether scaling can be performed, etc. is taken up ahead so that we can plan to take what all instruments we need to take when we go for oral care at their house. The next stage in the treatment process is home-based oral care. What we have developed is a team which is either consisting of the one faculty or the resident. Resident means the postgraduate. We routinely incorporate interns, and sometimes we also incorporate the final year students in our team. And we travel in the palliative care vehicle provided by the palliative care unit, which consists of the palliative care nurse, the ASHA worker, and a driver. These drivers are generally very resourceful, who help us handle our equipment very easily. Let me tell you, the portable unit that we know is a game changer. And I have talked to many medical people involved in palliative care who were really happy to see that we had this equipment which could take dentistry right to the bedside at their house. We don't use the portable chair because many a time it is very difficult to shift the patient. Rather, we use a chair available at the house or the patient's bed itself to perform the treatment. But the portable unit consisting of a scaler, suction is really useful. And of course, an aerotropon. All the instruments that are important are carefully considered, sterilized and packed and taken along with the unit. Remember, our mobile units may not be very useful because they may not go into the small roads that we usually have to go when we see in the government sector. And therefore, the small vehicle of the palliative care team is ideally suited for home-based oral care. Generally, we can do all kinds of basic oral care can be done. Selective grinding is really useful because it helps to relieve the irritation. Scaling can be done provided we have a scaler in the portable unit and a suction. And of course, we can do simple extractions. Here you can see extractions were done used patient in the supine position in their own bed. This was a mobile tooth of the lower arch where it was taken in patient in the sitting position. And these are all the feedback that we get from the patients is really good. They're very happy that they're able to get this at their house. So coming to the topic, whether palliative care is really important for dental public. The moment I say this, I know there can be many frowns among the faculty members of public health dentists, especially in the private institutions. The question that may come up in your mind is there space for more arrows? We know that we are already understaffed and all the miscellaneous things coming from tobacco cessation, the satellite clinics, the entire burden is on the dental public health department. So really, can we manage this extra requirement? I leave the decision to you with few points. So I have organized my discussion on palliative care and dental public health into 4 areas. I've identified them as strengths, skills, snags, and significance. Let us look at why I feel that palliative care should be taken up by the dental public health department. What are the available strengths or what are the available system advantages? Well, our department is a natural choice for outreach programs. And as I've already told you, the thrust of palliative care is on home-based care. So rightfully, PhD is the natural choice for carrying out home-based visits. Now, the KUHS curriculum has already identified BDS students to be trained under public health dentistry for palliative care. So that is yet another reason why I call it a strength. And we are already doing oral care for inaccessible groups, be it tribal populations, be it our slums, be it orphanages, be it our intellectually disabled population. So generally, the mandate for giving oral care for inaccessible groups comes upon us. And therefore, palliative care is only naturally our forte. Now, what skill sets do we possess to perform palliative care? I strongly believe that public health dentists have a special skill set which makes them truly suited for palliative care. We are very trained to work in resource poor conditions, in the most limited of conditions, because we are already doing outreach. Now, the integration with other healthcare workers comes naturally to us. And we have a broader view on social realities. Generally, our communication skills are something which we consider our forte. And therefore, these are some skill sets which may be really vital for performing palliative care. Now, there are, of course, some snags or some technical difficulties, the chief being limited manpower. This is a serious problem. When for an undergraduate college, there is only a requirement of 1 reader. This is very, very difficult to carry out all these activities, maintaining the quality. Yes, that is something which we have to overcome. Revenue generation is a big problem because palliative care in the government side is not about revenue generation. But of course, there are avenues in the private side also, in Ernakulam also. There have been requirements for palliative care from private centers. There have been calls which they ask us whether we can come to private hospices to provide oral care for the bedridden or for the elderly who are institutionalized. So yes, there may be a scope for private-public partnership and probably, but for revenue generation. But though this is a very big area of concern. The challenges to infection control, especially in pandemic times when all outreach programs have been withdrawn. Yes, it is a concern, but then definitely the future is going to be optimistic and these times will change. And if we plan carefully, we can deliver good quality care at the same time maintaining all infection control precautions. Now coming on to the significance. Definitely, these snags can be overcome as palliative care is going to be a renewed source of identity for the public health industry department. The fact that we can integrate with the existing healthcare delivery system will definitely improve our reach and will make us more visible in the society. And this in turn will have ripple effects in all our activities. So that is where I feel such initiatives are important. Definitely, this is going to be a huge motivation for students. Even at first, when I say palliative care, myself, I had some questions in my mind. Students, I have found in two minds when we ask them to say to go to home visit or to undergo training. But after they attend their first home visit, they're so happy. They feel happy that they can do something or can help such patients. So it's a big motivation. Also remember, we can provide good practical training to all many aspects of public health. Say, let it be determinants of health. Rather than focusing on the theory session alone, when we say there are not only physical determinants, there are social, there are mental, spiritual, etc. They can be exemplified when they visit a house, and then it's very clear to them what we mean by determinants. Similarly, we also can use the palliative care environment for improving communication skills, how to talk to a patient, what is non-verbal communication, etc. So these palliative care provides a plethora of opportunities for better practical training in dental public. So these are my viewpoints on why palliative care should be integrated or should be taken up wholeheartedly by dental public health departments. Now, there are avenues for training in palliative care. This is taken from an article by Dr. Suresh Kumar. There is only one hospital which provides PG degree in palliative care, that is the Tata Memorial Hospital at Mumbai. Still, such a course is not available in any other medical college in the country. There is a one-year residential follow-up program at CMC Vellore and Kidwai Memorial Institute of Oncology in Bangalore. There's a one-year distance education fellowship program at the Institute of Palliative Medicine, Kozhikode. I believe this is the time. I think there is time till July 31 when we can apply for the next course. There are quite a number of dentists who have done this course and are practicing palliative care. There are 8-week certificate courses conducted by the Indian Association of Palliative Care at 30 centers across India. And there are courses which offer residential training, 6 weeks and 4 weeks duration at the WHO collaborating centers at the Institute of Palliative Medicine in Kozhikode and Trivandrum, at Thrissur, and of course the district hospital in Ernakulam provides many courses. All these courses that I have mentioned are open for doctors as well as nurses. There are few other courses which are open only for nurses. The important point to remember is that all these courses are open to dentists. The eligibility criteria for all these courses, it's very clearly said that it is open to participants or candidates with BDS degree. So these are good avenues for training, getting trained in palliative care. Well, I'm coming to the end of my talk. These are my references. The policy of the government of Kerala is a public document, as well as the pioneers. They have written quite a number of good articles on this subject. Before ending my presentation, I would like to acknowledge the team members at Public Health Dentistry GDC Kottayam, my professor, Dr. Susan Thomas, assistant professors, Dr. Mary Shimi and Dr. Bindu Bhaskar, and all the past senior residents who have worked, Dr. Kevin Suresh, Dr. Jesslyn, Dr. Arun, and all my juniors who have really gelled as a team and in probably starting this first ever initiative in palliative care at the department. It is my thanks due to the IA-PhD Kerala chapter, the entire organizing committee of Phoenix to 2021, to having given me an opportunity to present my viewpoint on palliative care. The team at Online Dentistry is providing tremendous support for this conference. They must be thanked because unless for them, this would not be brought to you in this manner. The training on palliative care was given to us by the Department of Palliative Care at General Hospital Kottayam, and faculty members from Ernakulam were also involved, to whom our thanks are due. Dr. Vyasasukumaran, who is a district program manager of the National Health Mission at Kottayam, has provided vital support in our teething initiatives to start palliative oral care. It's really sad that this is not an interactive session, though I would really love to hear feedback, or regarding any queries, you may please email me at drviveknarayan@gmail.com. I hope it was a wonderful learning experience. And once again, thanking all of you for your patient listening. Thank you.